Welcome back to the deep dive. Today we are heading into the abdomen, but we're doing it with a very specific and frankly, a very intense lens.
We're looking at the liver and the biliary tree.
And look, I know exactly what you're thinking. You're thinking, I'm an ICU physician. I treat sepsis every day. I know how to treat a liver abscess. I know what cholangitis is.
Right.
You see a fever, you see a high white count, you throw Zosyn at it, and you call GI.
But do you really know it? I mean, do you know it strictly from a microbiological perspective, which is how we are, usually taught in med school? Or do you understand the hydrodynamics of it?
Exactly. That is the massive shift we are making today. We are moving away from the simple bug and drug model, just throwing antibiotics at a fever, and moving toward what our sources represent as the biliary pressure paradigm.
This is really the executive summary of this entire deep dive. If you want to master hepatobiliary infections specifically for you, the practicing intensivist who is managing these really sick patients at 2 a.m., you have to stop thinking of the biliary tree as just a biological tube. You have to start thinking of it as a high-pressure hydraulic system.
A hydraulic system that is actively trying to kill your patient if the pressure gets too high.
Precisely. We are going to explore this concept of the hepatic firewall, which is fascinating. We'll get into the specific mechanisms of failure, and then we are going to do, really, a masterclass on the 3 pillars of hepatic infection.
So liver abscesses, biliary emergencies like cholangitis.
And then the failure modes, the things that keep intensivists up at night.
So let's start with this concept of the hepatic firewall. It sounds like something out of a cyberpunk novel, but it's actually a sophisticated anatomical defense system.
It is. It really is. Think about the liver's position in the body. It is the gatekeeper. I mean, you have portal blood coming straight from the gut.
That's not clean blood.
Not at all.
Right.
It is loaded with antigens, food particles, toxins, and, yes, bacteria. It is essentially dirty blood, and it hits this firewall.
And this firewall isn't just one thing. It's a defense in depth.
Correct. It is a multi-layered system. First, you have the sphincter of Oddi at the bottom, which is the physical gate preventing reflux from the duodenum.
The first line of defense.
Then you have the chemical barrier, the biliary mucus and secretory IgA. And then you have the cellular barrier, the tight junctions between the hepatocytes and, crucially, the Kupffer cells.
The Kupffer cells are the resident macrophages, right? They're the cleaners.
They are the bouncers. That's a great way to put it. They line the sinusoids. Under normal conditions, they eat everything. They filter that blood so that by the time it exits the liver into the systemic circulation, it is sterile.
And the bile flow itself plays a role.
A huge role. Bile acts like a detergent. It flows down. It's a one-way street. That flow physically washes bacteria out. It prevents them from adhering.
Okay.
But the central conflict in all the pathology we're about to discuss, whether it's an abscess or cholangitis, is when that flow stops. Obstruction leading to pressure. And this is where the physics comes in. Our sources highlight a critical number, a threshold that every ICU doctor should have burned into their brain.
And that number is?
20 to 25 centimeters of water.
20 to 25 cmH2O. Why is that number so specific? It sounds like a ventilator setting.
It does, doesn't it? But in the biliary tree, that is the breaking point. When intrabiliary pressure exceeds that threshold of roughly 25 cmH2O, the tight junctions between the hepatocytes literally rupture.
The barrier physically breaks. It just gives way.
It physically breaks. This is the phenomenon known as cholangiovenous reflex.
Explain that for us. What does that mean in practice?
Once those tight junctions snap, bacteria and endotoxins aren't just sitting in the bile duct anymore. They are bypassing the Kupffer cells, which are the immune filter, and they are being injected directly into the systemic circulation via the hepatic veins.
It is a terrifying image. It's basically an auto-transfusion of sewage.
That is exactly what it is. And this is the key takeaway for the intensivist managing a patient in septic shock. Antibiotics cannot stop a hydraulic injection mechanism.
So the meropenem isn't the solution.
You can sterilize the blood all you want with meropenem, but if the pressure remains above 25 cmH2O, the reflux continues. You are bailing water out of a boat while there is a massive hole in the hull.
Which brings us to the mission of this deep dive. We aren't just reviewing guidelines. We are synthesizing the Tokyo guidelines to 2018, the TG18, along with recent randomized controlled trials and advanced pathophysiology to give you a roadmap.
A roadmap for when to drain, when to drug, and when to call the surgeon.
Right.
We're going to cover the great divide in liver abscesses, pyogenic versus amoebic. We'll look at the catastrophe of hypervirulent Klebsiella, And we will get very, very granular on grading the severity of cholangitis.
Okay, let's dive into Section 1, the physiology of defense and defeat. We touched on the firewall, but let's look at the unifying mechanism of sepsis here. The sources describe a sequence. Stasis plus bacterial growth equals pressure elevation.
Right. It's a cascade. It's a domino effect. You start with obstruction, maybe a stone, maybe a tumor, maybe a stricture.
Something is blocking the pipe.
Exactly. That causes stasis, bile stops flowing. Then bacteria, usually E. coli or Klebsiella ascending from the duodenum, start to multiply because that detergent flush is gone.
And as they multiply, they create gas, inflammation, and more fluid. It's a vicious cycle.
Which drives the pressure up. And this leads to what the sources call immune collapse. Hydrostatic pressure actually compromises the ability of the phagocytes, the neutrophils and Kupffer cells, to do their job.
Wow. So the pressure itself is immunosuppressive locally.
Exactly. So not only is the bacteria multiplying, but the local police force is incapacitated by the pressure.
And then comes the reflux we mentioned.
Yes. The transition from a local infection, my belly hurts, to systemic shock is driven by that reflux. The sources are very clear on this. Mechanical decompression is the physiological requirement to reverse septic shock in this setting.
Not antibiotics. Decompression.
You have to restore flow to lower the pressure below that 25 cmH2O threshold. That is the intervention.
Okay, keep that pressure paradigm in mind. We are going to apply that to our first major pillar, liver abscesses.
This is an area where I see a lot of confusion and, frankly, a lot of mistakes. Even experienced physicians can get tripped up here.
The sources call this the Great Divide. We have pyogenic liver abscesses, or PLA, and amoebic liver abscesses, or ALA.
And the distinction is critical. I mean, it is absolutely critical because the treatment is diametrically opposed. If you drain the wrong one, you're doing harm. If you don't drain the other one, you're doing harm.
Okay, so let's start with the amoebic liver abscess. This is caused by Entamoeba histolytica.
Correct. Entamoeba histolytica. It's a protozoan parasite. Now, just looking at the epidemiology, there's a fascinating signal here. The male to female ratio is 10 to 1.
That is massive. That's not a subtle difference. Usually in infectious disease, you see maybe a slight skew, but 10 to 1. Why men?
It's one of those deep dive nuggets that makes you rethink physiology. There is data from animal models suggesting that testosterone is actually a risk factor for the development of the abscess.
Testosterone.
It somehow modulates the immune response, specifically cell-mediated immunity, allowing the amoeba to take hold in the liver. It's quite remarkable.
So testosterone is effectively an immunosuppressant for this specific bug.
In the context of the liver, yes, it seems to be. So your classic patient is a young or middle-aged male, maybe an immigrant or a traveler returning from an endemic area, India, Africa, Central America.
Or, and the sources note this, men who have sex with men are also a high-risk demographic, even in non-endemic areas, due to fecal oral transmission.
Exactly. Don't miss that history. It's a key part of the social history to ask.
Now, pathogenically, how does this happen? The amoeba starts in the gut.
It starts as a cyst you ingest, it exists in the lumen, becomes a trophozoite, and invades the colon wall. And interestingly, you don't always get dysentery.
Oh, that's a huge clinical blind spot.
It is. You can have the liver abscess without any active diarrhea.
So asking, do you have diarrhea, and getting a no doesn't rule it out.
Absolutely not. The amoeba travels up the portal vein, and it causes hepatocyte apoptosis. It literally tells the liver cells to kill themselves. This creates this pool of necrotic fluid.
And this fluid is famous.
The anchovy paste. It is thick, chocolate-colored, odorless fluid. And here's the kicker. It is usually sterile.
Sterile? How can an abscess be sterile?
Because it's not pus. Bacterial co-infection is rare, less than 5%. If you culture anchovy paste, you usually get nothing. It's liquefied, dead liver tissue, not a soup of bacteria and neutrophils.
Okay, so that is a massive distinction. Now, contrast that with pyogenic liver abscess.
Pyogenic is pus. It's bacteria and neutrophils. This is a disease of the elderly, usually. The incidence is about 1 to 4 per 100,000, but it's been rising.
And unlike the amoeba, which just swims up the portal vein, pyogenic abscesses have a classification system based on route. The sources list 5 routes. Let's walk through them because this really helps with the detective work at the bedside.
Right. Number 1, and the most common, is biliary. This is 40 to 50% of cases. A stone blocks the duct, you get cholangitis, and the bacteria invade the liver parenchyma.
And these are often multiple abscesses.
Yes, very often multiple, and they often communicate with the biliary tree itself.
Okay, then you have the portal vein route.
This is classic pilophlebitis.
Mhm.
You have appendicitis or diverticulitis. The septic thrombus shoots up the portal vein and seeds the liver.
Then hepatic artery, what causes that?
Hematogenous seeding?
Hmm.
Think endocarditis. Staph aureus in the blood finding a home in the liver. These tend to be microabscesses scattered everywhere.
And direct extension.
From a nasty gallbladder or even trauma. The sources mention a specific case of a swallowed toothpick.
A toothpick.
A swallowed toothpick penetrating the stomach wall and migrating directly into the liver.
That sounds incredibly painful. And finally, cryptogenic.
The mystery cases. But as we'll discuss in a moment, cryptogenic is often code for hidden Klebsiella.
Let's hold that thought on Klebsiella for a second and talk diagnosis.
Yeah.
The classic triad is fever, jaundice, and right upper quadrant pain.
And the sources say, forget it, it's only present in 10% of patients.
10%. That's useless.
It's worse than useless, it's dangerous. If you wait for the triad, you will miss 90% of abscesses. Most patients just have fever, malaise, maybe some weight loss. It looks like failure to thrive in an elderly person.
And jaundice.
Jaundice is actually rare in amoebic abscesses. It's a bit more common in the pyogenic ones, especially if they are biliary in origin, but it's not a reliable sign.
So we have to rely on imaging. What are we looking for on the CT scan? What are the buzzwords?
For pyogenic, look for the double target sign. You have a central fluid collection, an enhancing inner rim, that's the abscess wall, and a hypodense outer edema ring.
Okay, I can picture that. What about the cluster sign?
That's highly suggestive of pyogenic. It looks like a bunch of small grapes fusing together. They are aggregating and coalescing into a larger cavity. It tells you there's an ongoing process.
And the honeycomb sign.
That implies septations. When you see a honeycomb, your brain needs to go to two specific bugs, Klebsiella, or if you were in Southeast Asia, Melioidosis.
Good to know. Okay, diagnostic testing. If I suspect amoebic, what do I order?
You need E. histolytica serology. The sensitivity is good, about 65 to 92%. But remember, in endemic areas, a positive serology might just mean past exposure.
So it's not a slam dunk.
Not always. There's also an antigen detection test for the galgalnac lectin, which is more specific for active disease. And emerging tech like cell-free DNA is showing promise with up to 90% sensitivity.
And for pyogenic, we need the bug.
You need the bug. Blood cultures are positive about 50% of the time, but the money is in the aspiration. If it's pyogenic, you aspirate pus, and that culture is positive 80 to 90% of the time.
Which brings us back to the microbiology deep dive. We mentioned Klebsiella. We need to put a spotlight on hypervirulent Klebsiella pneumonia, or HVKP. This isn't your grandfather's Klebsiella.
No, this is a distinct and terrifying syndrome. It emerged from Taiwan and Korea about 2 decades ago, but is now global. This bacteria has a hypermucoviscous phenotype.
The positive string test.
Exactly. If you touch a colony on a plate with a loop and pull up, it stretches a string of mucus longer than 5 millimeters. It's incredibly sticky. It's armed with these K1 and K2 capsule serotypes and specific cyrophores like arobactin that make it incredibly resistant to phagocytosis.
And the clinical picture is different.
Very different. It affects diabetics, it's community acquired, and the really scary part is the metastatic complications. Unlike normal Klebsiella, this one likes to travel.
Where does it go?
It goes to the eyes endophthalmitis and the brain meningitis.
The sources cite a rate of 10 to 16% for metastatic infection.
That is huge. That's 1 in 10 patients. If you have a diabetic patient with a liver abscess and they mention their vision is a little blurry, that is an ophthalmologic emergency. They can go blind rapidly.
So if you see a community-acquired liver abscess in a diabetic, especially if they're of Asian descent, you are thinking HVKP until proven otherwise.
Absolutely. You need to screen for metastatic sites. It's part of the workup.
Let's move to section 3, management. We've diagnosed the abscess. Now, what do we do? Let's start with the amoebic strategy.
Medical therapy first. This is a medical disease. The drug of choice is metronidazole.
It's a dose.
750 milligrams 3 times a day for 7 to 10 days.
And the response is usually pretty good.
Very good. Fever typically resolves in 3 to 5 days. It's quite dramatic.
But there's a trap here, a step often missed.
Yes. The luminal follow-up. This is so important. Metronidazole kills the invasive trophozoites in the liver, but it doesn't do a great job on the cysts still sitting in the intestine. So you treat the liver, the patient feels better, you send them home, and they're still carrying the parasite. They're a walking reservoir.
So they can relapse or infect others?
Exactly. You must use a luminal agent like paromomycin to eradicate the cysts in the gut, even if they don't have diarrhea. This is the board question step that really, really matters in real life.
Now, the big controversy. To drain or not to drain? For amoebic.
Generally contraindicated. Do not put a needle in an amoebic abscess if you can avoid it.
Why? What's the risk?
Because medical therapy works so well, and introducing a catheter introduces the risk of secondary bacterial infection. You turn a sterile anchovy paste into a pyogenic abscess. You create a superinfection where one didn't exist.
But there have to be exceptions.
Of course. 3 main ones. 1, if it's massive, greater than 10 centimeters, the risk of spontaneous rupture is high. 2, if it's in the left lobe and dangerously close to the pericardium.
Because if that ruptures into the heart.
It causes tamponade and is rapidly fatal. And 3, if you've treated for 3 to 5 days and they aren't getting better, or if you just aren't sure if it's pyogenic or amoebic, then you aspirate for diagnosis.
Okay, flip the script. The pyogenic strategy.
Drainage is key. This is pus. You have to get it out. Antibiotics penetrate abscesses poorly. You need source control.
Does size matter here?
It does. It absolutely does. The guidelines generally say if it's small, let's say less than 3 to 5 centimeters, you might get away with antibiotics alone or simple needle aspiration.
But if it is greater than 5 centimeters?
You need a catheter. You need percutaneous catheter drainage, PCD. The meta-analysis data is very clear that PCD is superior to needle aspiration for success rates and speed of resolution. You leave the drain in until the output drops to almost nothing.
And antibiotics for pyogenic abscess.
Empirically, you need to cover the gut flora. So ceftriaxone plus metronidazole is a great community regimen. If it's healthcare-associated or biliary in origin, you might step up to piptazo to cover Pseudomonas and Enterococcus.
What about duration? We used to treat these forever. 4, 6, 8 weeks.
Traditionally, yes, 4 to 6 weeks was the standard. But there is a very important study mentioned in our sources, the Singapore RCT by Moulton and colleagues.
This looked at oral versus 4.
Yes, specifically for Klebsiella liver abscess, which is, a very common cause. They found that oral ciprofloxacin was non-inferior to 5-E ceftriaxone.
But there's a huge caveat, right?
A huge one, provided that drainage occurred.
That is a game changer for getting patients out of the hospital.
It is. It reinforces that if you have good source control, meaning the drain is in and it's working, the antibiotics can be oral and highly effective. The drain is doing the real work.
All right, let's move from the liver parenchyma into the plumbing itself. Section 4. Acute cholangitis, the biliary emergency.
This is where the pressure paradigm we talked about in the intro becomes a matter of life or death within hours.
Definitions first. Cholangitis is inflammation of the bile duct caused by obstruction plus bacterial growth.
And remember the signs. Charcot's triad. Fever, jaundice, right upper quadrant pain. But as we said, low sensitivity. Don't hang your hat on it.
And Reynolds pentad adds hypotension and confusion.
Right. When you see confusion and hypotension in a jaundiced patient, that signifies septic shock. That means the hepatic firewall has failed and you have uncoupled high-pressure reflux.
We are going to use the Tokyo Guidelines 2018 framework here because it's the global standard. They have a diagnostic criteria. A, systemic inflammation, plus B, cholestasis, plus C, imaging.
But the real meat, the part that you need to know on a night shift, is the severity grading. This is the decision matrix for the intensivist. It tells you how fast you need to run.
Let's break it down. Grade 3, severe.
Grade 3 is defined by organ dysfunction. This is the sickest of the sick. If the patient is hypotensive requiring pressors, has a low GCS, confusion, respiratory failure with a P to F ratio less than 300.
Renal failure.
Renal failure with a creatinine over 2, or coagulopathy with an INR over 1.5, or platelets less than 100,000.
Any one of those.
Any single one of those puts them in grade 3. And the action plan is urgent decompression.
Urgent means?
ASAP. Ideally less than 24 hours, but functionally, as soon as you can stabilize the hemodynamics enough to get them to the GI suite, or R, this is a physiological emergency. You cannot fix grade 3 with antibiotics alone. The pressure is too high.
Okay, grade 2, moderate.
No organ failure yet, but they look sick. You see 2 or more of these high-risk signs, WBC greater than 12,000, a high fever over 39 Celsius, age over 75, or a low albumin.
So they're teetering on the edge.
Exactly. These patients have high-risk signs, and the action for them is early decompression. You have a little more time, but don't sit on it.
And finally, grade I mild.
No organ dysfunction, no high-risk signs. They meet the criteria for cholangitis, but They're stable.
What's the plan for them?
You can try antibiotics first. If they don't improve in 24 hours, then you drain.
Let's talk about source control modalities.
Yeah.
How do we get the pus out? How do we decompress?
The gold standard is ERCP, endoscopic retrograde cholangiopancreatography. You go down the throat, find the ampulla, cut the sphincter, that's a sphincterotomy, pull out the stone, or put in a stent to bypass the obstruction.
Why is it the gold standard?
Because it restores the natural flow. It's internal drainage, it uses the body's own plumbing, and there's no bag hanging on the outside.
But sometimes you can't get there. Maybe they had a gastric bypass or the tumor's too high.
Then you go percutaneous. PTBD, percutaneous transhepatic biliary drainage. A needle through the liver from the skin into a duct, and you place a drain.
So an external drain.
An external drain. And then there's the emerging tech, EUS-guided drainage.
Endoscopic ultrasound.
Exactly. Using endoscopic ultrasound to punch a hole from the stomach or duodenum directly into the biliary tree and place a stent, it's becoming a really viable alternative to PTBD, avoiding that external bag.
What about antibiotic duration for cholangitis?
Stop early. Once you have source control, once that bile is flowing, the guidelines say 4 to 7 days is plenty. And emerging data suggests even 3 days might be enough if the patient is clinically well.
Because the drainage does the heavy lifting.
The drainage does 95% of the work.
Section 5, acute cholecystitis. We have calculus with stones and a calculus without stones.
Right, and 90 to 95% are calculus. The cystic duct gets blocked by a stone, the gallbladder gets inflamed and infected.
And the standard treatment is early laparoscopic cholecystectomy.
Right. Get the gallbladder out, usually within 24 to 48 hours. But if the patient is grade the third, severe, septic shock, or has a massive comorbidity index, they might be too unstable for surgery.
In that case, we use the PC tube, percutaneous cholecystostomy.
It's a bridge. You put a drain in the gallbladder to relieve the pressure and resolve the sepsis. Then you figure out the surgery later, or maybe never if they are just too frail.
But let's focus on the ICU phenotype, acute acalculous cholecystitis.
This accounts for only 2 to 15% of cases overall, but in the ICU, it's a major player. This is the patient who has been in the unit for 3 weeks on a ventilator.
What are the risk factors?
Trauma, burns, TPN, prolonged mechanical ventilation, sepsis from other causes, basically any severe critical illness.
What is the mechanism if there is no stone?
It's ischemia and stasis. The gallbladder isn't emptying because the patient isn't eating, so there's no CCK release. The gallbladder wall gets ischemic from shock or from high-dose pressors. You get necrosis of the wall.
A diagnosis is a nightmare because these patients are sedated and intubated.
Exactly. They can't tell you they have a positive Murphy sign. You just see an unexplained fever or a sepsis that isn't clearing despite broad-spectrum antibiotics.
Ultrasound.
It can be equivocal. You might see a thick wall or some sludge. But is it inflammation or just edema from their critical illness? A CT scan is often more helpful to look for pericholecystic inflammation or gas in the wall.
And the management?
Time-sensitive source control. If you suspect AAC in an unstable ICU patient, percutaneous cholecystostomy is often first line. It's both diagnostic and therapeutic.
How so?
If you stick a needle in and pus comes out, you were right, and you've just fixed the pressure problem.
Moving on to Section 6, special populations. Let's talk about the immunocompromised host.
Specifically, AIDS cholangiopathy. This was huge in the pre-ART era, but we still see it in patients with advanced, untreated HIV.
What are the bugs? It's not the usual suspect.
No, it's Cryptosporidium, CMV, Microsporidia, these opportunistic pathogens.
And the presentation is unique.
Yes, you get papillary stenosis. The pathogens cause fibrosis of the papilla and the ducts themselves. You get these sclerosing cholangitis-like changes on imaging.
And labs. Is there a telltale sign?
A disproportionately high alkaline phosphatase. The bilirubin might be normal or only slightly elevated, but the ALK+ is sky high, in the thousands.
What about transplant recipients?
Liver transplant recipients live and die by their biliary tree. They get strictures and leaks at the anastomosis site. And because they are so immunosuppressed, you have to worry about weird bugs like aspergillus or multi-drug-resistant bacteria.
Let's talk parasites, the liver flukes.
Clonorchis sinensis and Opisthorchis. These are acquired from eating raw freshwater fish, primarily in Asia.
And long-term risk isn't just infection?
No, the long-term risk is cancer, cholangiocarcinoma. The chronic inflammation from the fluke infestation drives malignancy over decades.
And then there is Ascaris, the roundworm.
Ascaris lumbricoides. This worm is big. It's like a small earthworm. It can physically migrate up the common bile duct from the intestine and cause a mechanical obstruction, just like a gallstone.
Wow. Okay, one more complication that is easy to miss, pylophlebitis.
Septic portal vein thrombosis.
Definition.
It is an infected clot in the portal vein, usually seeded from another intra-abdominal infection.
How do you spot it? What are the clues?
You have a patient with an abdominal source, let's say diverticulitis, who has persistent fever and bacteremia despite appropriate antibiotics for the diverticulitis.
So you're treating them, but the fever just won't go away.
Exactly. That's when you need to get a CT with contrast looking specifically at the portal vein, and you'll see the thrombus.
And the treatment for that.
Long-term antibiotics. 4 to 6 weeks at least.
What about anticoagulation?
It's controversial. The sources say you should consider it if the thrombus is progressing or if it extends into the mesenteric veins, because that risks bowel ischemia, which is a catastrophe.
All right, Section 7, the failure modes checklist. This is for when you are standing at the bedside on day 4, the patient is still febrile, still on pressors.
The why aren't they better checklist. This is crucial.
Item 1, is source control adequate?
Don't just assume because a grain is in, it's working. Is it clogged?
Yeah.
Has the pigtail catheter migrated out of the collection? Did you miss a second abscess next to the first one, that cluster sign?
So you have to reevaluate.
You have to flush the drain. Image the drain. Make sure it's actually doing its job.
Item 2, is microbiology correct?
Are we treating for E. coli, but it's actually MRSA? Or fungal, especially in an immunocompromised patient? Or, and this is the classic mistake, is it amoebic and we are giving ceftriaxone instead of metronidazole?
Item 3, is the diagnosis correct?
Is that abscess actually a necrotic tumor that won't get better with a drain? Is the primary source of sepsis not the liver at all, but actually a calculus cholecystitis that we missed?
And finally, item 4, are there complications?
Did we miss the metastatic endophthalmitis from that hypervirulent Klebsiella? Did they develop pylophlebitis on top of their diverticulitis? You have to broaden your search.
Okay, we've covered a mass amount of ground. This has been a true masterclass. Let's bring it home with the outro and synthesis.
If you take nothing else away from this deep dive, remember the pressure paradigm.
Yeah.
In the biliary tree, flow restoration is the primary treatment for sepsis.
It's a plumbing problem.
It's a plumbing problem first, an infectious disease problem second. You cannot cure grade 3 cholangitis with pills and 4 bags alone.
And remember the great divide for abscesses.
Do not drain amoebic abscesses unless you are forced to. Do drain pyogenic abscesses if they are of a significant size.
And the Tokyo criteria.
Grade 3 means organ dysfunction. Grade 3 means move fast. It is a time-sensitive emergency.
Okay, leave us with a final provocative thought, something for us to chew on.
We talked about antibiotic duration. The future is shorter. It has to be. We are seeing data that says if you have adequate drainage, if you fix the plumbing, do we really need 4 weeks of pills for a liver abscess? The Singapore study suggests oral is fine.
And for cholangitis.
Emerging data suggests 3 days might be enough for cholangitis if you get good drainage. I think in the next decade, we will realize that the drainage was doing 90% of the work, and our 6-week antibiotic courses were, in many cases, just treating our own anxiety.
Treat the pressure, not just the bug.
Exactly. Look at the liver not just as an organ, but as a plumbing system where pressure dictates survival.
That wraps up our deep dive into liver and biliary infections. For the ICU physician, remember, the liver is a filter, the bile duct is a pressurized pipe, and when the firewall breaks, you need to call the plumber. Thanks for listening.
Stay curious.